edition of Young Guns webinar, this time from Gujarat. Now, traditionally, Gujarat SFM has been one of the most active members of SFM. It has got one of the largest number of members. Plus, they have a very vibrant and an active WhatsApp group. They have a lot of excellent academic discussions that they take place on that group. But there are very young people who are inclined towards quality work and they share phenomenal cases. I think what SFM has done with Alok and Varun, they're providing excellent platform for these young people to publish their cases on a national scale. So we're really looking forward to this discussion. And to take it forward, I would want Dr. Girish Patel, the past secretary of the Gujarat chapter, to take over the proceedings from here. Over to you, Girish Bhai.
Unmute Dr. Girish.
Dr. Girish, you have to unmute yourself.
Respected mentor, Dr. Ashok Khurana sir, Dr. Mohit Bhai, Dr. Alok, our president, Dr. Mayank, Secretary Vaishakhi, and all the office bearers and our respected other office bearers of the National Body of the Society of Fetal Medicine, and our young participants. Today is the day for which we were waiting for. After that Karnataka SFM body, they did a fantastic Young Guns webinar. We were also waiting the same. And Dr. Vaishakhi and Dr. Alok, they have really worked hard in making these presentations so that we can also take proud of our Gujarat chapter of Society of Fetal Medicine. I hand over this to Vaishakhi. Vaishakhi, please take over. Hello?
Yes, yes.
Yes.
Okay. So to begin with, we are going to start with the webinar of limb abnormalities, and Dr. Kalpana Kathrotia is going to begin with the very common abnormality, which is talipus. So very simple abnormality, but maybe hiding some differential diagnosis or deeper complexities. So I would like to invite Dr. Kalpana Kathrotia to share her screen.
Yes, ma'am.
Dr. Kalpana Kathrotia
Yes,
is MS OBGY with her fellowship in fetal medicine from New Civil Hospital, Surat. She is working as fetal medicine consultant since last 7 years, and she is presently honorary visiting fetal medicine consultant at New Civil Hospital. She is working at Kiran Hospital, Devki Hospital, and Unicare Hospital. Her academic interest has made her to publish a lot of papers and posters in the index journals of world. Over to you, Dr. Kalpana.
Thank you, ma'am. Thank you for the kind word. Very good evening, respected teachers, seniors, and dear friends. I would like to extend my sincere gratitude to Ashok Khurana sir, Girish Patel sir, and Vaishakhi ma'am, and all other seniors for giving me this opportunity and also giving me a chance to share my knowledge. Today, my topic is a twist in the ankle or twist in the story. First of all, we learn the brief anatomy of the foot. Foot is divided into 3 regions, that is hindfoot, midfoot, and forefoot. Hindfoot contains talus and calcaneus. Midfoot contains navicular, cuboid, and 3 cuneiform bones. And the forefoot contains 5 metatarsals, 14 phalanges, and 2 sesamoid bone. Now, club foot, that is also known as a congenital talipus equinovarus, is a complex congenital deformity of foot involving bone and soft tissue of hindfoot, midfoot, and forefoot. It is a combination of 4 elements, that is cavus, adduction, varus, and equinus. Cavus of foot means unusually high arch foot like a cave. Metatarsal adductus is a 4-foot turned inwards. Heel varus is heel is tilted inwards, and equinus is the foot pointed downward with heel lifted off the ground. The foot affected by clubfoot is shorter and calf circumference is less than the normal unaffected foot. How the foot is developed? Foot develop in 3 stages. First stage is early embryonic period, during the foot is in the line with the leg. Second stage is fibular phase. During this phase, larger growth of the fibula as compared to tibia leads to physiological club foot. And third stage is tibial phase. During that, acceleration of growth of tibia, so the foot attain its normal position. Now, what happened to the foot that lead to the club foot? As we have seen these two phase in earlier slide, during fibular phase, lateral angles of feet increases, and during tibial phase, lateral angles decreases. So the club foot occur when transition from fibular to tibial phase fails, leading to fixed inversion, adduction, and equinus. Incidence is club foot is very common, 1 to 2 newborn per 1,000 birth. Club foot may be unilateral or bilateral. It is twice common in male as compared to female, and it may be isolated or associated with other malformation that is complex. In majority of the cases, the club foot is idiopathic, and in around 20% it is associated with other disorder. Club foot congenital talipes equinovarus is a multifactorial in origin, and it have a genetic factors, neuromuscular factor, connective tissue abnormality, vascular factors, and mechanical factors too. Now, what is the ultrasound findings? Diagnosis is based on visualization of plantar surface of foot in the same sagittal plane as tibia and fibula. In image A, we can see fibula and tibia, but we cannot see the foot. And in image B, we can see fibula, tibia along with the foot, and it is suggestive of club foot. It can be detected as early as 13-week gestation through transvaginal sonography, and by 16-week by transabdominal sonography. Before 13 weeks, plantar flexion or adduction of the foot can be a normal developmental finding. International guidelines recommended identifying both the legs and the feet in a typical second trimester fetal ultrasound scan, but description of position and relationship is unnecessary. Particular attention is placed on lower extremity joint motion as well as overall movement of the fetus. Joint, we should look for the hip joint movement, knee joint, and ankle, and also the movement of toes if we are suspecting club foot. In this video, this is the normal foot, and showing that if we can see the tibia and fibula, we cannot see the foot, and vice versa. Both segments cannot be seen simultaneously if the leg is normal. Ultrasound sensitivity is as high as 81%. If the fetus is diagnosed with isolated club foot prenatally, approximately 11% are later found to have other abnormality postnatally, and thus subsequently it is recategorized into the complex club foot. 30% of complex club foot can be associated with chromosomal aberration, and clinical significant microarray results are detected in approximately 4% of isolated club foot. On USG, it may be persistent, transient, or relapsing. Multiple images should be observed, preferably with movement of leg away from the wall of uterus. In case of mild deformity, it is more difficult to diagnose because both the segments are not parallel as in the classic club foot. The false positive rate of diagnosis of isolated club foot ranges from 10 to 40%. Now we will see the each and every cases one by one. This is the normal first trimester fit. Here we can see both the segment are perpendicular to each other, both the side. Case 1, first trimester suspected unilateral club foot. I have mentioned suspected because before 13 week we cannot label it as a club foot because it may be a physiological finding. This is the one is the normal, and here we can see the inward rotation of foot and angle is increased. This is the second case, second trimester unilateral isolated club foot. Here we can see the unilateral club foot, and normal second leg is completely normal. This is the second trimester bilateral isolated club foot. Rest of the anatomy is completely normal. So we have sent the whole exome sequence, and a report is awaited. This is the case for bilateral complex club foot. Other than the bilateral club foot, posterior fossa is obliterated, and there is a cystic lesion over the sacrococcygeal lesion, that is the open neural tube defect. Case 5 is a bilateral complex club foot in which Other than bilateral CTV, here we can see the severely dilated both ventricles, single umbilical artery, and perimembranous VSD. Due to the multi-system involvement, patient opted for termination. In case 6, unilateral complex clubfoot. This patient is around 28-year-old with conceived after ovulation induction with high BMI. Anti-scan was normal outside. Here we can see one foot is clubbed. Severe asymmetrical IUGR during the 22-week scan, along with perimembranous VSD. Here we can see the left foot is clubbed, left hand is also clubbed, bilateral bilactasis. Right femur length is normal, that is 40 mm, and left femur is short and bowed. Its length is around 31 mm. So the multiple abnormality, patient decided for termination. These are the post-abortal pictures. Here we can see the short femur along with the club foot and club hand along with the oligodactyly. We advise the patient for the whole exome sequence, and it came positive for heterozygous autosomal dominant Verhage syndrome. They labeled as an uncertain significance, but the classical features are characterized by the growth retardation, delay psychomotor development, dysmorphic phase, skeletal abnormality, and cardiac defect too. So there are the 2 to 3 features. They are matched in our case too. That is growth retardation, skeletal defect, short femur, and cardiac defect, that is perimembranous VSD. Case 7 is recurrent clubfoot. The patient was primigrida, 23-year-old, first degree consanguineous marriage, came at 19 weeks. During her anomaly scan, there is only isolated clubfoot, rest of anatomy appear normal. Patient delivered at 7 months at her village with USG findings suggestive of hydrops and polyhydramnios. Now patient came to us again during the second pregnancy, and anti-scan was done, and there is a suspicious of unilateral clubfoot. During the anomaly scan, there is early onset of fetal growth restriction with maternal and fetal Doppler was normal, and bilateral club fit, persistent right umbilical vein, and single echogenic foci. As there is a previous history of similar defect and first degree consanguineous marriage, parents were counseled for invasive testing. Amniocentesis was done, and it came positive for congenital myopathy 22B severe fetal type, and it was also uncertain significance. But what is this defect? It is autosomal recessive muscle disorder characterized by the utero onset of severe muscle weakness, manifest as akinesia, and there is development of polyhydramnios, and affected individuals develop fetal hydrops with pulmonary aplasia and severe joint contracture. So geneticists advise parents targeted mutation. We have done that, and both parents shows autosomal recessive similar mutation. Now the twist in the story occur. Patient continued the pregnancy, came for the growth scan at around 28 weeks. At that time, there is a bilateral pleural effusion, ascites, polyhydramnios, and limb are in the classic position of like is in the Arthrogryposis. Patient went into preterm labor, and this is the fully fledged picture of Arthrogryposis. We can see the limb posture as in the Arthrogryposis. Eighth case is unilateral complex clubfoot. One left foot is a clubbed and right is a normal, and there is a along with that there is a diastematomyelia. Now prenatal counseling, complete detailed sonogram is necessary to uncover other anomalies and other intrauterine and also the congenital uterine anomalies like bicarbonate uterus, fibroid synecdoche, and amniotic bend. Key reassurance is isolated clubfoot highly correctable. Genetic testing is also necessary. A follow-up scan is necessary for evolving anomalies, as in our case like arthrogryposis and other neuromuscular disorder. And a reference to the pediatric orthopedic surgeon for counseling before birth is also necessary. The treatment is available in form of conservative treatment and minor surgical intervention. In conservative treatment, we can see stretching, for example, like the French functional method, and serial casting and bracing like the Ponseti technique, which is an excellent long-term outcome technique, most commonly used right nowadays. It involves 6 to 8 weeks of long leg plaster from the toe to the groin with a gentle manipulation of talus. Casts are changed once a week. This is the 5-stage. Orthopedics are preferred to do the around 5 to 7 stage treatment according to the severity of leg deformity. And they are give it as early as possible after birth if baby weight is more than 2.5 kg. Minor surgical intervention like Achilles tenotomy, tibialis anterior tendon transfer, Achilles lengthening, and use of external fixative devices. So what is the take-home message? Detection at 18 to 22 weeks can always check entire fetus for other anomalies. There is a role of genetic testing in complex clubfoot, and genetic test is advisable in isolated clubfoot too, as there is a chances of abnormal chromosomal aberration near 4%. Isolated CTEV is benign and more than 90% is correctable. Routine obstetric care is unchanged, vaginal delivery is safe, and early counseling set up for the orthopedic team, explain cast and brace schedule, and it has an excellent prognosis. Normal walking, sports, and lifestyle is expected. Thank you so much for patience listening. Thank you so much.
Dr. Kalpana, that was an excellent presentation. Your different type of cases have set a reminder to never overlook what seems common. Okay, so now we are moving to the next case, which is the missing radius more than just a bone. I would like to invite Dr. Cherisa Reninga. Dr. Cherisa, please share your screen.
Yes, ma'am.
Dr. Cherisha is going to take us to the upper limb, where a missing radius can open up a world of differential, whether it is isolated or is it syndromic. Dr. Cherisha has done her MBBS from GCS Medical College, and she has done her PG from Radial. She has done her fellowship in fetal medicine from Fetuscan Training Center, and at present she is working as an obstetrician and fetal medicine consultant at Dhatri Hospital, Banaskantha. Over to you, Dr. Cherisha.
Good evening, everyone. Today, I myself, Dr. Cherisa, I will be presenting my case on radial aplasia. So, coming to the incidence part, incidence is between 1 in 30,000 to 1 in 100,000 live births. It is bilateral in half and slightly more common in males than in females. Most of them are sporadic with only about 20% familial. Now coming to the diagnosis part, here the rhizomelic part of the upper limb showing the humerus is normal, whereas the mesomelic part showing aplastic radius, hypoplastic radius and moderately hypoplastic ulna. Aplasia radius is associated with acrodactyly, that is absent of thumb, except in case of TAR syndrome in which the thumb is present. So this is the ultrasound image of aplasia radius, in which the radius is absent, ulna is present, and bowing of the hand towards the radial side. Now coming to the Heckel classification of radial dysplasia. The image in the blue box showing the normal anatomy of hand, and in the red box showing the different type of dysplasia. Type 1, there is shortening of distal part of the radius, which is greater than 2 mm. Type 2, there is shortening of distal part of radius, but it is less than half of its length. Type 3, there is shortening of radius, but is more than half of its length. And in type 4, there is complete absence of radius. In all four, there is bowing of the hand, and the bowing angle gradually increases towards the radial side. Now coming to time of detection. A good time is to detect during the anti-scan, because during that trimester, the limbs are often stretched out. It must be detected during anomaly scan. This anomaly is widely believed to occur within first 10 weeks of gestation. Now coming to my case 1, a 28-year-old primary patient came for anti-scan at 13-week period of gestation. She had no significant past personal and family history. Patient was vitally stable with normal hematological profile. So this is the ultrasound video of the fetus. Hands appear severely deviated. They are club hands and severely shortened radial bones in both forearms, and no other anomalies were found. So the diagnosis was isolated bilateral radial aplasia. This is the image of the abortus fetus. The couple opted for termination of pregnancy, and the abortus fetus confirmed the prenatal diagnosis, showing bilateral club hand. Now coming to the etiology part, Exact cause is not always known, but it is associated with various following factors. Firstly, environmental factors. Exposure to certain teratogens such as valproic acid, retinoic acid, and thalidomide may increase the risk. And poorly controlled diabetes mellitus also increases the risk. Secondly, is vascular disruption during fetal development, as in case of amniotic band syndrome. Thirdly, is genetic mutation such as those affecting SALL4 gene and RBM28 gene. Now, fourth one is the syndromic association in which aplasia radii are found. These are Holt-Oram syndrome, TAR syndrome, and Fanconi anemia. Now, next 4 to 5 slide, I will be showing the syndromic association with radial aplasia, which are also the DD of radial aplasia. First one is Holt-Oram syndrome, also called heart-end syndrome. The first image showing congenital heart disease in which there is ASD. The second image showing syndactyly. This is partial syndactyly. This is complete syndactyly. This one is ultrasound image of syndactyly. Second one is the Robert syndrome. First image is congenital heart disease. Second showing the cleft lip. And the third showing the phocomolia, in which there is shortening of all 4 limbs. Thirdly, showing the Nager syndrome. The first image showing the micrognathia, second showing the normal external ear, and the other one showing the malformed external ear, in which the lobe is absent and the curvature of the helix and antihelix are malformed. Now the image of the fetus of Nager syndrome, showing aplastic radius, micrognathia, and low set ears. Now, the image of the TAR syndrome, in which the radius is aplastic but thumb is present. This is only the DD in which the thumb is present in aplasia radial. So, this slide I took from Pellegrini, showing the DD of aplasia radius and various syndromic association, which I discussed previously. Now, coming to my case 2, which is third trimester soccer, G3P2L2. 24-year-old patient came for anomaly scan at 28-week period of gestation. She has no significant past personal family history and no history of consanguineous marriage. Patient was vitally stable with normal hematological profile. Now depicting my USG video. On ultrasound, the right upper limb appears the normal. The left upper limb shows severely shortened forearm with short radius and ulna, and left hand is not visible. It's clearly showing in USG. Now, counseling of couple was done for invasive procedure, but they refused and continued the pregnancy. So, postnatal, the confirmed ultrasound finding was severely malformed, severely shortened left forearm with absent of the left hand. So, the diagnosis was terminal transverse limb defect. Now, coming to my case 2, a 32-year-old G2P1L1 patient came for anti-scan at 14-week period of gestation, past history of isolated bilateral club foot in previous child. On ultrasound, this was bilateral club hand and bilateral club foot was detected. The couple opted for termination of pregnancy and the abortus confirmed the prenatal diagnosis, showing the bilateral club hand with bilateral club foot. Now coming to my management part. After asking thorough past personal and family history, I would like to go for the following routine hematological profile and the further investigation, which are NIPT, fetal echocardiography, and the invasive procedure are chorionic villi sampling and the amniocentesis. Now, genetic testing. First one is target gene specific testing to detect the genetic mutation with the following syndrome, such as TBX5 gene, which is associated with Holt-Oram syndrome, RBM8 gene associated with TAR syndrome, FANK-A, FANK-C, and FANK-G with Fanconi anemia. Secondly, chromosomal microarray analysis to detect copy number of variation or chromosomal abnormalities. Thirdly, exome sequencing to detect the mutation in coding region of genes. Now, factors affecting the prognosis. Firstly, severity of the deformity. Milder case of better outcome. Secondly, associated anomaly. If the fetus is associated with heart defect, blood disorder, or systemic anomalies, it may impact the prognosis. Treatment and management. Early intervention with physical therapy may improve the outcome. Now coming to the treatment part, it is mainly of 2 types. non-surgical and surgical. Non-surgical is mainly done using stretching and manipulation and using external fixation. In stretching and manipulation, the main aim is to align hand and wrist with the ulna. It is done using various splints and serial cast. External fixation is done for children with more severe radial dysplasia. Now, surgical treatment. It is mainly done by the orthopedic surgeon. The main aim is to centralize the wrist, straighten forearm, and reconstruct the thumb. Timing of the surgery. So, depending upon the severity of the condition and other medical associated condition, the treatment is started. But it is best started as soon as possible after birth. Now, take-home message. So, time of detection. Good at time of the anti-scan, but must at anomaly scan. Whether to continue or not, let the couple decide after explaining them possible outcome. Thirdly, the treatment should be started as soon as possible after the birth, and genetics plays a major role in it. And at last, I would like to thank my mentor, Dr. Rohit Sanghani sir, Dr. Toral Panchal madam, an entire Society of Fetal Medicine, Dr. Ashok Khurana sir, Dr. Mohit sir, Dr. Girit sir, Dr. Alok sir, and Dr. Vaisakhi Valia madam. Thank you everyone for your patience listening. Thanks.
Thank you so much, Dr. Cherisha. It was a very nice presentation with interesting cases. You have shown us the approach, how to look at the club hands. So now let's move towards another interesting case, which is twice told signs when the limbs and face speak the same language. I would like to invite Dr. Sukriti Chandra. Dr. Sukriti, please share your screen. As we know, this femoral hypoplasia with unusual faces syndrome, where limb abnormalities and facial features goes hand by hand. So our next speaker is Dr. Sukriti Chandra. She has done her fellowship in fetal medicine from Rajni Fetal Medicine Center, and she is a consultant fetal medicine at Divam Imaging and Fetal Medicine Center at Vadodara. Over to you, Dr. Sukriti.
A very good evening to all my seniors and my colleagues. Today I'm going to present two interesting cases of femoral hypoplasia unusual faces syndrome. And it is very true in my case that it is a twice told sign when the limbs and the face speaks the same language. So starting with my case 1, 21-year-old primary, non-consanguineous marriage with no significant comorbidity. She presented at 14-week 2-day for the nuchal scan. This is the axial section of the lower limb at the level of proximal femur, in which we can see bilateral hypoplastic femur, or I can say barely femur bones are visible. This is the video clip showing the same, in which we can see bilateral femur are very hypoplastic or barely visible. This is the second video clip, in which we can see the upper extremities are normal and only the proximal part of the lower limb, that is the femur, are hypoplastic. This is the profile view of the same fetus, in which micrognathia is very evident, and the same we can see in the coronal section of the face, in which mandibular gap is absent, which signifies indirectly micrognathia. Now coming to my case 2, a 27-year-old gravida 2 para 0 abortion 1 non-consanguineous marriage. She was a known case of diabetes. No FTS was done, and she presented at 16-week 5-day for the early anomaly scan. This is the video clip in which we can see bilateral femur bone are hypoplastic. This is the USG showing the separate measurement for the both right and left femur. And we can see by biometry, the measurement of both the femur bones are falling below the first centile. This is the surface rendering image, in which we can see the short proximal segment, that is the short femur. This is the facial profile of the same fetus, in which we can clearly see the micrognathia. This is the volume contrast imaging in a skeletal mode, in which we can see the micrognathia. These are the surface rendering images in which we can clearly see the long philtrum and the micrognathia. So the diagnosis of femoral hypoplasia unusual facies syndrome was given, and in both the cases, the patient opted for the termination of the pregnancy. So this is the picture of the second abortus in which we can see long philtrum, micrognathia, and the short proximal segment of the lower limb. Now coming to the discussion part, femoral hypoplasia unusual facies syndrome has two components. The first one is the underdeveloped or absent femur, which is often bilateral, maybe unilateral also. And it has the typical facial features like short nose with a broad nasal bridge, long philtrum, micrognathia, cleft palate, or upslanting palpebral fissure. It can have the other associated anomalies also like vertebral, cardiac, genitourinary, or neural tube defects. Now coming to the causes, exact pathology is not known, but yes, it is frequently associated with a maternal diabetes. According to one paper by Lee et al., the 37.8% of all the cases of the femoral hypoplasia unusual facies syndrome were linked to the hyperglycemic mother. The other causes could be oligohydramnios, and the third one could be sporadic gene mutation, but it is also very rare. Now coming to the differential diagnosis, the first and the very close one differential diagnosis in this case will be caudal regression syndrome. The similarity between two is that both are found in diabetic mother and both are associated with the femoral hypoplasia. But difference is that the caudal regression syndrome is associated with the partial or complete absence of sacrum or lower lumbar vertebra anomaly, and facial characteristic will be absent in caudal regression syndrome. The second close DD will be proximal femoral focal deficiency, in which femoral hypoplasia will be present, but facial characteristic will be absent. The third one is the cyanomelia, in which there will be femoral hypoplasia, fusion of the limbs, renal abnormality, or absence of sacrum. The fourth differential could be skeletal dysplasia, like campomelic dysplasia, in which generalized skeletal system will be involved, and along with that, there will be bowing of the bones. So just a quick summary tip regarding the DD. If the facial anomalies plus femoral hypoplasia, think about FHUFS. If spine abnormality predominate, think about caudal regression. And if only femur is affected with no facial feature, think about PFFD. Now, how to counsel and investigate the case? It requires a multidisciplinary, structured, and empathetic approach. It starts with taking the proper history. As I said earlier, it is frequently associated with the maternal diabetes. Genetic testing in these cases are questionable because till date no specific gene mutation has been identified, and further studies are needed to specify any to investigate any specific gene mutation. Now, second step will be discussion of the prognosis with the couple. It should be emphasized that it is a non-lethal condition and cognitive development of the baby will be completely normal. But yes, there will be mobility limitation due to femoral hypoplasia, and there will be requirement of multiple orthopedic surgeries and prosthesis, and facial features will also require correction. Discuss the option of termination if the diagnosis is made early and if the family desires for it. But if the couple opt for the continuation of pregnancy, then tertiary center delivery should be recommended with the birth planning with the neonatal team. Psychological support should be provided to the couple, and the follow-up USG for the growth and AFI should be done. And after the delivery, postnatal X-ray of the baby and the reassessment should be done to plan the further management. So, sweet take-home message in my case would be always measure the long bones routinely. In case of doubt, take the bilateral measurements. Always and always look for the face in the case of femoral shortening, and be alert in the case of maternal diabetes due to frequent association. Thank you very much for the patient listening. Thank you very much.
Dr. Sukriti Chandra, thank you so much for the wonderful presentation. You have solved this complicated prenatal puzzle very well. Thank you so much.
Thank you.
Now I would like to invite our trade partners to show their innovation in the world of ultrasound. Mr. Vishal.
Atul, can we play the trade partners video, please?
So before that, we should, I think Mayank Chaudhary is also here. No?
Dr. Mayank has joined?
Yes.
Okay, okay. Can I invite Dr. Mayank to give his comments? Dr. Mayank, are you there?
Yes, good evening to all, and thank you, sir, for motivating us for doing such a wonderful CME. And we all know that SFM, the main motto is always to promote a young talent, and they have a fresh idea, fresh mind. And today's initial three talk was very thorough, detail, and they cover each and every aspect of scanning and postnatal management of the cases. And I hope that next remaining cases are also that much interesting. And in future also, we will do such type of CME more frequently. And in near future, you will meet personally also. Thank you very much. Thank you all. Thank you, Ashok sir. Thank you, Mohit sir.
Okay, everyone. Now we are moving towards our next case. We are shifting our focus to the structural bowing abnormality, the bow that heals, the natural history of CPM BTF abnormality. I would like to invite Dr. Brijesh Kumar. Dr. Brijesh, please share your screen. Dr. Brijesh Kumar is going to guide us through a case of congenital bowing of tibia and fibula, which challenges both prenatal diagnosis as well as the counseling. He has done his MBBS and MD from BJ Medical College, Ahmedabad, and he has private practice at Pujan Hospital, Ahmedabad since last 22 years. He has been the part of Fetuscan training program. Over to you, sir. Dr. Brijesh.
Am I audible?
Yes, sir.
Okay. So, sorry. That Titanic started first voyage from to New York, and in the ocean, it was struck by iceberg, and that unsinkable vessel sank, and around 1,500 passengers were killed. Why? Because it overlooked the iceberg-prone area. It was speeding higher than expected, 22 nautical miles rather than 18 nautical miles. And few safety measures were missed. So they missed the protocols and accident happens. Similarly, we have also protocols, guidelines like ICOG tells us that for limb anomaly, the presence of all long bones and their symmetry, length, shape, alignment, position, and movement should be assessed. If you will follow these protocols, you will not miss any icebergs and no accidents. My case, my patient came in 2021. She was primary patient, 20-year-old, non-consensuous marriage, anti-scan was not done, no even antenatal care was there, no other positive history, no exposure to any chemical or toxic substance. We did 23 weeks ultrasonography. In anomaly scan, everything was looking fine from head to brain, from brain to heart and lungs to abdomen, everything was fine. But when we are looking at the long bones, we see that there is some discrepancy in right and left tibia. So there was a shortening of tibia. That right tibia fibula was shorter by 11 millimeter. At that time, we were not sure about diagnosis, but first thing came to our mind was hemimelia. So we counsel the patient and call her for the follow-up. Then we review our case. There were three possibilities: CPMBT, hemimelia, and pseudoarthrosis. So we review our image also. At that time, we thought there is dorsiflexion of foot and angle valgus, and so it is matching to congenital CPMBT, but we were not sure. So we pushed help button. What is help button? Help button is SFM WhatsApp group in which you put your query, your doubt, and some senior will definitely help you out. At that time, Dr. Manikandan sir confirmed our diagnosis at CPMBT, and we were thankful to him. So now what is CPMBT? CPMBT, as its name suggests, it is congenital posteromedial bowing of tibia. And it is accompanied by ipsilateral calcaneo-valgus deformity. Incidence is very rare and mostly unilateral. Only one case has been reported by Shah et al. Having bilateral CPMBT. Cause is unknown, but important thing is prognosis. It is having very good prognosis, spontaneous resolution of angular deformity with some residual limb length discrepancy and angle valgus, and moreover, no genetics involved. Treatment part, most of the patient have spontaneous resolution. Few needs physiotherapy, and rarely orthopedic intervention may require after 6 to 7 years. But for differentiation between those three diagnoses, we need to understand the direction of bowing, tibial bowing. We can understand here, if tibia is bowing posteromedial, then it is CPMBT. If it is anteromedial, it is hemimelia, and if it is anterolateral, it is pseudoarthrosis. Why it is important? Because prognosis of all of these are different, and congenital CPMBT is having very good prognosis. So when patient came after a month, we were confident with our diagnosis. Everything was looking fine, but that baby was worrying, what will be my prognosis? So at that time also there was difference of around 11.5 millimeter in both tibia. At that time, patient and relative were counseled properly. All options were discussed in detail regarding the prognosis and postnatal management. Then patient came after a month and a half. At that time, color Doppler was fine. Even growth was also fine. But that difference between right and left tibia was there. It was around 12.4 millimeter. After that sonography, patient delivered at other hospital. It was vaginal delivery, male child, 2.7 kilograms weight. We communicated to her and she told us that at the time of birth, approximate difference between both tibia was 13 millimeter. We maintain good communication to patient. So at 6 months, they sent us this image. We compare this image with our old image of 23 weeker. We can mark out that there is improvement in angle, but still shortening was there. And just before 2-3 weeks, that boy came to our hospital, and at that time, we can have these recent photographs. If we see here, right foot is still short and there is some angular deformity is also there. But when we ask him to walk, now watch, functionally it is almost gone. So functionally it is almost fine, no other problem. But when we measure the limb, still there is 20 millimeter difference is there. And luckily at that time we can have X-ray also. In X-ray also there is little bit posterior bowing and medial bowing of right side of tibia. Why it is happening? It is happening because of remodeling. Remodeling is happening because of diaphysial and physial realignment. Because of that, growth plate, and this muscle, this calf muscle, gastrocnemius muscle and soleus are pulling that foot down, so that dorsiflexion angle is correcting. And then we all together insert the details from 23 weeks to 4 years in this table. Left tibia was normal, right tibia having deformity or shortened one. So difference in millimeter is varying from 11 millimeter to 20 millimeter. Nothing great, but when we convert that difference into percentage, we can see that it is varying, it is decreasing from 28% to 8%, particularly after birth, it has decreased significantly. So when we put this in a line diagram, here also we can mark it that after birth, significant resorption is happening. We go through few cases, few literature. Jollinger first of all detected or documented in 2000 first case. There were 2 cases. Then only few cases available in literature for antenatal diagnosis. So learning point of our case study is always follow protocols and measure all limbs whenever there is doubt and document it. And if you are not satisfied with diagnosis, don't worry, review it and seek guidance. Go for help. Don't shy for that. Do proper counseling and good follow-up. CPMBT is mostly self-healing deformity, and isolated CPMBT, generally no testing is required. Thank you, SFM, and thank you, Dr. Rohit Sangani. Thank you very much.
Thank you so much, Dr. Brijesh Kumar, sir. Your case was a very strong case with a clear message on expectant management in CPMBT. Now I would like to invite Dr. Paras Ravan to present the next case, fixed in the womb, the log joint mystery. Dr. Paras,
Dr.
please share your
Paras is
screen.
not here right now.
Dr. Paras is not there?
No.
Okay. So now I would like to invite our next presenter, Dr. Bhumika Shah. Dr. Bhumika, will you please share your screen? Dr. Bhumika is
Yes,
going.
ma'am, I'm sharing.
Yeah, Dr. Bhumika is going to speak about extra digits and extra questions. She is going to decode polydactyly. Dr. Bhumika at present working as fetal medicine consultant in X-ray House Anand, and she is a visiting faculty of fetal medicine fellowship at Sri Krishna Hospital, Karamsad. She has presented paper in UFOXY 2020 and won the 3rd prize, and she has presented paper in Sonocon 2022. So Dr. Bhumika, over to you.
Good evening, seniors and all my colleagues, and thank you everyone for the opportunity. So my topic, extra digits, extra question, I'll try to justify my topic. So generally, whenever we are examining, there are 2 questions always in our mind. Should we count the fingers? And if by chance we detect a polydactyly, should we go for genetic testing, even when it is isolated? So let us try and understand this. Polydactyly, it is when one or more extra digits are present. If it is on the ulnar or the fibular side, it is called as postaxial, PAP. If it is on the radial or the tibial side, it is called as preaxial, PPD. And the rarest variety when it is the central. So I'll move on to my cases. My first case, she was a second gravida paraman. She was referred for first trimester screening at 14 weeks gestation. There was no significant family history. Her previous child was also normal. Her first trimester screening was low risk, but there was an incidental finding of right hand preaxial polydactyly, which was noted. Findings were explained to the patient and her husband. So this is the finding. This is the first trimester. And this is the normal other hand, showing the normal fingers. And here we could see the polydactyly. And the rest of her scan was normal. So a follow-up scan was done at 22 weeks, which confirmed our initial finding, and there was no additional scan finding found. Patient was explained for the isolated nature of the condition, and genetic evaluation was offered, but patient refused for the same. She had a full-term delivery, male child was born, and the findings were confirmed postnatally. The baby is presently 4 months old, doing well. However, this digit will require excision because of its location. My second case, she was a primary patient. She was referred for anomaly scan at 18 weeks. There was no significant family history. Her first trimester screening was low risk. Second trimester, second trimester scan, it showed bilateral post-axial polydactyly of upper limb, and we suspected a polydactyly of foot. There was relatively mesomelia, means the tibia fibula and the radius ulna, they were between 5th to 10th centile, and the humerus and the femur were at 30th to 40th centile. So apparently it was an isolated finding of polydactyly. So this is the video showing polydactyly here. And here we suspected there is some extra digit, but however we could not confirm it. And this is the polydactyly in both the hands. This is the 3D rendering showing the same. There was no significant for positive family history. Scan revealed no other major anomalies. In view of scan findings, patient was counseled for genetic testing, which they agreed on, and amniocentesis was done. Amniotic fluid was sent for microarray and whole exome sequencing. This whole exome sequence is showed a deletion in EVC2 gene, which causes Weyer's acrofacial dysostosis. This is the report of the baby. Now, because it was deletion of EVC2 gene with no other cardiac condition, we also went and tested the parents, and the parents did not show the mutation of EVC2. However, the uncertain significance, it was there in mother, so which was a normal variant. A bit about EVC2 mutation. This is the same mutation which, when associated with polydactyly and cardiac anomaly, it causes Ellis-Van-Creveld syndrome. And in this phenotype, there is severe short stature with dysmorphic features, and there can be neurodevelopmental delays in 9%. However, when EVC2 mutation has polydactyly only, means there are no cardiac features associated, it causes Weyer's acrofacial, or it is also called as Weyer's acrodental dysostosis, where there is just mild short stature and there may be some dental or nail dystrophies. There is no reported cases of mental retardation seen in Weyer's acrofacial dysostosis. This same was explained to the parents, and this is the kind of dentition, like from conical teeth to widely spaced teeth to absent dentition, and some dysmorphism of nail which can be expected. But however, the patient still opted for termination for pregnancy, and the pregnancy was terminated. And postnatally, the findings of polydactyly with also central polydactyly in both the lower feet was confirmed. I move on to discussion. So polydactyly, it is one of the frequent congenital hand malformations. The incidence is reported for 0.7 to 1.3 per thousand live births. Exact incidence in India is not known. However, in Asian population, in one of the Chinese paper, it is reported to be as high as 16%. It has ethnic and racial variations. So normal ultrasound timeline, if we see, by 8 weeks, we can see the limbards. By 11 weeks, there is bone ossification. And by 12 weeks, mostly there is ossification of the metacarpals. Fingers can be clearly seen as early as 13 weeks. But the ideal time, according to literature, for seeing the exact fingers is in the second trimester scan. If we move on to the etiology, most of the cases, they can be isolated. There is familial tendency of inheritance. There is a disorder in programmed cell death during fetal development, which causes polydactyly. Pre-axial, it is due to ectodermal or pre-axial mesodermal apoptosis disturbance. And post-axial, it is due to excess expression of SSH in ZPA. Abnormal expression of genes like Sony Hedgehog, Hoxbach, and bone morphogenic proteins and GLI3 has also been associated. So prenatal diagnosis and management. whenever it is diagnosed on an antenatal scan, we have to remember that it can be either non-syndromic or it can be a part of syndromic condition. So once diagnosed, a thorough ultrasound evaluation of heart, brain, limbs, and kidneys should be done, because it can be also a part of ciliopathy. And many syndromic conditions which are associated with it are trisomy 13, where there is CNS anomalies and growth restriction; Meckel-Gruber, where there is encephalocele with cystic kidneys; diabetic embryopathy, where of course with the history of diabetes in mother, there can be associated cardiac, renal, or skeletal malformation; Smith-Lemli-Opitz, there is CNS abnormalities; Carpenter syndrome, there is craniosynostosis with mid-phase hypoplasia, and there can also be some cardiac defects; Pallister-Hall syndrome, where there is pituitary hematoma; Greek cephalopolysyndactyly, where there is macrocephaly; Townes-Brooks syndrome, where there is imperforate anners and abnormal ear morphology; and Holt-Oram syndrome, where there is associated cardiac anomalies. So why is there a need for genetic evaluation? Because Society of Maternal and Fetal Medicine revealed that polydactyly is associated with more than 100 genetic syndromes. Advances in human genetics have revealed several new isolated and syndromic kind of polydactyly, and genetics in polydactyly is highly complex. Several factors like variable expressivity, incomplete penetrance, difference in genetic background, environmental influence, and epigenetic phenomena play roles in developing differential phenotypes in human. And correlation between ultrasound findings and genetics is necessary to predict the exact phenotype in cases of polydactyly. So this is a list of genes. There are a lot of genes which is even involved in non-syndromic, and a lot of genes involved in a syndromic variety of polydactyly. I would like to share this recent paper that is published in 2025. They had a large cohort of almost 55,000 pregnancies, from which they found out 328 cases of polydactyly. Of these, only 63 were detected prenatally, 265 were detected postnatally. So the detection rate was 19.2%, and from these, maximum were detected in the second trimester, that is 14.2%. 157 cases were isolated and 171 were non-isolated. And the most common kind of polydactyly was post-axial, and in foot, most common was pre-axial. Syndactyly was the most common abnormality that was associated. Fetus, they say that when fetus, there is isolated polydactyly or polysyndactyly without any other abnormalities, it is not warranted to undergo invasive prenatal testing for karyotype alone. However, if we are planning for a genetic testing, then at least CN chromosomal microarray and whole exome is required, because conditions also polydactyly associated with karyotyping alone will not give us much outcomes. But they still say that more evidence is needed to advise whole exome in all the cases of polydactyly. The limitations of the study was that it was a single center study, and they did not use more complex classification related to syndromic cases, and classification which is essential for prognostication was not included. Many polydactyly cases were not evaluated by genetic evaluation, so they did not have an exact correlation of the ultrasound and genetic findings. And most important thing, that there was no history of parents, which is very critical in cases of polydactyly, was not included. Based on this, this is a small flowchart which we can include, that if we diagnose polydactyly, firstly we need to see about the history. If history of similar condition is present in the parents, then we can expect a similar phenotype to the parents, because most of the cases it is familial. Then we need to move on to complete head to toe evaluation. We need to see for craniosynostosis, heart, kidneys, brain development, facial dysmorphism. And we need to decide whether it is non-isolated or isolated. In non-isolated cases, of course, we go for amniocentesis or CVS for genetic evaluation, and we go for microarray followed by whole exome sequencing. And we need to also understand the familial trends. In isolated cases, amniocentesis, genetic evaluation should be offered. However, we need more data to confirm it. Take-home messages: even though it is not a part of guidelines, but effort should be put to evaluate limbs beyond wrist and ankle. early diagnosis, it helps to look for associated anomalies and genetic syndrome, if any. There is a less element of surprise for family. Like if it has been diagnosed prenatally, the parents are prepared for these condition. And genetic evaluation should be offered in non-isolated cases. Even when isolated, some cases may have major functional and cosmetic role, and early treatment can be helpful. Thank you for your patient listening, and I thanks the society for helping me, making me present this. Thank you.
Thank you so much, Dr. Bhumika. It was a very nice case presentation, fully worked up cases, and you have shown a very nice way how to go ahead when we see a polydactyly on scan. Now I would like to invite Dr. Paras Ravan. Dr. Paras, please share your screen.
Yes.
He is going to speak about fixing the worm, the log joint mystery. So now Dr. Paras is going to tell us to look beyond the bones, the muscles and the fetal movement. Over to you, Dr. Paras.
Thank you, Dr. Vaishaki Madam. Firstly, I would like to thank Dr. Ashok Khuranak sir and the SFM local office bearers of Gujarat team for giving me this opportunity to present my work. So,
Paras, you can stop your video
I
camera.
think light चला गया क्या उसके इधर?
नहीं, Paras.
Light.
Let me contact him through phone.
By the time I will just introduce Dr. Paras. Dr. Paras is practicing obstetrics and fetal medicines from 4 years post PG. He is practicing fetal medicine and serving the most interior and unreached area of Gujarat since 2018. Currently, he is working as consultant in
Vaishaki,
fetal and
Paras.
gynec imaging.
Paras is joined because I am just contacting in phone. Paras, you are seeing our screen? अच्छा लाइट गई. Okay, okay. Okay, okay, okay. No problem. Vaishaki is joining.
वैसे ही लगा वो blackout हो गया एकदम. You can start with the next.
Yes. Vaishaki, we can invite the next one.
Sir, we are, Dr. Paras is the last presenter.
Okay, okay.
So maybe
we had
we
total
can take
6
question
cases today.
answers tab tak by the time you can join.
Yes.
Dr. Alok is there?
Yes, I am here. Mohit sir, your comments so far?
No, it is excellent. See, the thing about young guns is even we are learning so much by the meticulous organization, images, and the information that they provide. I think, Dr. Alok, this has been a phenomenal hit, and I'm looking forward to more participation from all over India, especially Gujarat, because Gujarat has got so many people who are actually so willing, enthusiastic to participate with such good cases. But this is phenomenal. I congratulate all the participants so far for phenomenal presentations. And I think Paras has joined.
Paras has joined.
Are you on, Paras?
Yes, sir. Sorry for the interruption.
No problem, no problem. We'll connect with you again. Yeah. Carry on, please, Paras.
Can I share my screen?
Yes.
Yeah, please do.
Yes, so let us see what is there in our first part. First part, that is arthrogryposis. This is the case 1, gravida 2, para 1 leaving 0. The
Paras,
pelvic...
I can't see your screen, Abhi. Please. Maybe you can reshare again.
Yes, sir. Yes, sir. Can you see my screen, sir, now?
Yes, but go full screen.
Yeah.
Yes, sir. Yes. So this is the first case showing previous pregnancy, delivered prematurely at 30 weeks of gestation, and the baby died in the NICU after 30 days of stay due to several complications. No genetic testing was performed. Only this photograph is available from the past pregnancy. And at this Can you see my screen?
Yes, Dr.
Full
Paras.
screen kar, full screen, Paras.
Go to full screen, yeah.
But why am I am able to see only the Zoom meeting?
So you pull up the screen. तेरा cursor लेके take your screen up, you will see the bar below.
Yes, yes. Now I can see my screen.
Yeah. So click on that bar now.
Yes, sir. So the couple was referred for anti-scan.
Your screen is not full screen, yeah.
These are the anti-scan images from the same case.
No.
They are not even.
We can see now normal structures during the first trimester scan. There were no abnormality detected at the time of anti-scan, and again the couple came for anomaly scan at 22 weeks, which again showed no abnormality in the fetus, as we can see in these pictures. The heart is normal, the abdomen is normal, everything is normal. But I was not able to see the hands because the hands were remaining in my checklist. Baby was persistently having clenched fist, and I was not able to see the hands, as we can see here. So I called the patient on the second day, as I was not able to see the hands. And on the second day, I was still not able to see the hands. And then I asked the detailed family history again, which revealed the positive family history of neurodevelopmentally abnormal relatives on both maternal as well as paternal side of the fetus. And again, I was not able to see even on the next day, even on extensive scanning for 30 minutes targeting only the hands, I was not able to see the open hands. But at some point of time, I could see the index finger and thumb moving, but again, there were persistent clenched fists on both the sides. We can see in these clips also, the hands are persistently in clenched fist position. So amniocentesis was done for QA-PCR for common trisomy, which was found as negative. And instead of our advice as try a whole exome sequencing, due to affordability issues, the family opted for the testing of the fetus only. Meanwhile, the report was awaited. I checked the previous picture of the baby of the previous pregnancy, which showed low set ear, abnormal position of the right hand, and some more abnormalities. With the help of I can see with the help of ChatGPT also, I could find some other dysmorphology features also. And the report came as there was likely pathogenic variant was found in the SINE1 gene, which was showing heterozygous. And the disease, these genes, the gene is responsible for causing arthrogryposis multiplex congenita 3 myogenic type, Emery Dreifuss muscular dystrophy 4 autosomal dominant type, spinocerebellar ataxia autosomal recessive type. And the lab suggested that the family should undergo further testing because only one mutation was found in the gene. And the lab suggested that chromosomal microarray and parental testing should be performed. But no further testing has been opted by the family. Pregnancy is continued. It is around 36 weeks now, and the growth is on lower side, and no new anomalies have developed. So what can be the cause in this pregnancy? This can be a current pregnancy, can be a recurrence of autosomal recessive or any other type of genetic abnormality, or this fetus can be a carrier for the genetic condition. The case 2 is second gravida, para 2 living one, previous healthy child, non-consanguineous marriage, no significant family history, and anti-scan showed polydactyly, persistent left superior vena cava, umbilical vein draining directly into the heart. And these are the clips of some of the clips of the same case. This clip is showing anti-scan of 3 vessel trachea, we showing persistent left superior vena cava. This is the abnormal umbilical vein draining directly into the heart without any turbulence. This is the 3D image of the same. This is the picture, video clip of the polydactyly. The limb is the hand which is below is showing 5 fingers and the above one is showing polydactyly. This is the 3D image. Hence, amniocentesis was done for this case at 17 weeks after doing a thorough anatomical scan, which found no new abnormalities, and the microarray test was also normal. So at 23 weeks of gestation, I found severe hydrops, no movement at all at any joints of limbs, and non-visualization of stomach bubble. This is the video clip of 23 weeks scan, persistently clenched hands and no movement at all joints. This is the 3D surface rendering images of the limbs, which is showing persistent flexion at the elbow and thigh, and also at wrist joints. This is the video clip showing the abnormal skull edema, severe bilateral pleural effusion. No abnormality was seen as such in the cranium. So these are the possible differentials after studying the OMIM, and with the help of the ChatGPT, I found these possible differentials. These are lethal multiple pterygium syndrome, new Laxova syndrome, hydrolethalus syndrome, Smith-Lemli-Opitz syndrome, Simpson-Golabi-Behmel syndrome, lethal congenital contracture syndromes, fetal akinesia deformation sequence. So what are the take-home messages from these two cases? The case one emphasizes on the family history. As I had almost completely finished my anomaly scan, but the persistent clenched hands and the detailed family history insisted me to go for further genetic testing in this scan. And a targeted scan should also target hands of the fetus, as often we overlook the hands when we see no abnormality in any other structure of the fetus. And the case 2 gives us the message that we should perform anti-scan as first trimester anomaly scan, as the subtle findings can give us enough time to investigate the case properly. A single genetic test will not suffice as microarray in this case, as it was normal. And seemingly subtle findings can progress to severe and lethal anomalies, like subtle findings like persistent left superior vena cava and polydactyly can give rise to hydrops and arthrogryposis. So hopefully we will be able to know final outcome for both these cases in future webinar. Thank you for giving me this opportunity. Thank you again.
Thank you, Dr. Paras. It was a great close to today's academic journey.
Thank you, ma'am.
Thanks, thanks,
Yes,
Dr. Vaishaki. Thanks. I think the young guns, they were firing from all the cylinders, no? They were hitting all the targets so effortlessly. No? So all of these are gifted. All of these are very hardworking. Their presentations were excellent, to the point, very crisp. The cases were, as usual, very, very nice, informative, well worked up. I first of all thank Gujarat SFM chapter, particularly Vaishaki, for curating all the presenters, all the cases, and putting up a grand show. This is fantastic. And I thank Khurana sir and Mohit sir for giving me the opportunity to mentor all these young people.
No, I'm sorry to interrupt you, Alok, but this was a phenomenal brainstorming idea from you and Varun that has led to the tsunami of young guns wanting to present, and it's a wonderful feeling. It's a wonderful feeling, and it's a great platform to mentor them. And I think everybody gets that kind of satisfaction. I'm sure your Vaishaki has got the satisfaction of getting them all together and mentoring them. And Alok, eventually everything reaches out to you. So I thank Dr. Girish Bhai for starting this momentum. I believe Gujarat gained momentum under Girish Bhai, and it will continue to do so as he keeps inspiring people. Dr. Vaishaki is, now doing phenomenal work, and we look forward to more and more participation from Gujarat, because what we saw today was amazing. And I'm sure they still have so much up their sleeve that we can keep doing it for a year or so. Lovely, lovely. Keep it up. Keep it up, young guns. Let's see more and more of you.
Dr. Khurana, sir, are you here?
I think Khurana sir is not there.
No,
Really?
Khurana sir is pretty much
Yes.
there.
He's-
Okay.
Poor
So-
connectivity. Yeah.
Yes, so I would like your comments
You
first,
know,
and I would also like you to answer the few questions which are there about whether we require genetic testing for clubfoot. Is it required for unilateral, bilateral, or not? Do we require it? Because I know that nobody can tell this better than you.
well, you know, when we first discovered club feet, that we could see them on an ultrasound scan, it was much after we discovered ultrasound. And at that time, the only genetic test that we used to have in the late 90s was a karyotype, which never yielded very much. And so it was generally decided that you don't need genetic evaluation for club feet. Now, in this particular situation, we said, okay, so we won't do it. We'll discover it, and then the parents can decide what they want. And typically in those days, life was easier, and they used to carry on with the pregnancy. The next step that happened was that they said, well, maybe we're not picking up enough, and some of the with new machines coming up with poor technology, we started missing out on some of the trisomy 18s. And then they said, no, so a karyotype is necessary. And then we realized, no, ultrasound improved again. So by 2003, there was a consensus that we will do karyotype. And then ultrasound said, well, ultrasound is good, nothing required. And then we keep quiet until suddenly 3 years ago, someone says, and this is a Chinese group that says, look, there is almost a 6% incremental yield for helping to discover conditions where the parents might decide that they do not wish to carry on because they might be a compromised quality of life, and that we do it. Now, when you have a paper that comes out like that, then you really get stuck with having to offer it to a patient. And this is why all the guidelines that we have don't seem to work. That technology moves so fast that we just cannot manage the fact that we are in a situation where a group decides that it is useful. Nobody else has decided that. They seem to have the largest collection in the world. Then you realize that they are associated with a laboratory that might be promoting this rather than an actual situation where you understand that, look, they were working as a single group and the results that came out were this. But it's pooled data that's come to them because they happen to be running a lab. So then we're left at a complete loss. So what I do then is I offer it to my patients. I say, look, there's a good chance that we may discover something in genetics, but there's a good chance that we may not. And very often, if we do discover something in genetics, it may have no implications whatsoever, and you might still have to get things repaired. In that situation, then, of course, the whole family comes into play and they decide what is to be done, whatever is their own practical wisdom. But this is going to continue for a few years, that for every single technological advance that we have in genetics, we're going to have changing indications on whether this is indicated or not indicated. What I'm hoping is that with the availability of these very deep exome sequencing that has come on, we might actually have far more information on how to use this, because one test seems to fit all these conditions. We've been wanting one test in genetics to say, okay, let's do this test and I will get as much as possible. We know that genome at the moment is giving us too much information that we can't handle, but a good, nice, deep exome sequencing will really be the answer, instead of first trying to see, okay, let's first do a microarray, then we will do an ordinary exome, or we'll do a clinical exome, and then move on to a deep exome. I think the answer really is that with new technology coming in, we will have new indications. For the moment, because of that one single paper that came in from China 3 years ago, we're going to have to suggest invasive testing for club feet.
So, Dr. Girish, would you like to comment on this? What's your experience?
No, I don't have so much experience on the club feet, but previously what we were not investigating, bilateral club feet, Now we are definitely investigating the patient, and we are getting in one patient we have got something. Otherwise, our trend has now changed so that we love to investigate bilateral club feet.
I think by and large we are shifting towards invasive procedures,
Correct.
even for minor, abnormalities which we used to ignore previously, but now
Yes.
we are investigating them extensively.
That's
If we investigate 1,000 cases, we are bound to find something or the other in one or two.
and the so-called these genetics people writing insignificant woos, they are now becoming pathogenic woos, and they are taking responsible for the disaster. No.
Yes. Yes, it is very tricky these days. Can we have another questions? Can we take another questions?
Yes, yes, this is.
Yes. Okay, so the other question that is there, we have dealt with the club feet. Then we have the question, what is the minimum size discrepancy which is normal between the long bones, the tibia, fibula, radius ulna, which will be considered normal? So let's say if I measure the humerus on both sides, what will we consider as within the normal range, and when should we start to worry? So is there a percentage, percentile, or some absolute millimeter difference? Uh, can the young presenters take this question, if possible?
Sir, can I answer this question?
Yes, please.
Sir, there is no specific measurement at what discrepancy should be between the long bones, but that discrepancy of more than 5 or more than 2 standard deviation indicate the skeletal dysplasia.
I believe, we should not judge it on one scan alone. Okay. First of all, if we ever have a discrepancy, we should cross-check it again. And if we still have a discrepancy, how much ever millimeters it is, we should follow it up for an interval scan to see whether that discrepancy is increasing. And if it is increasing, then we should be worried. If you look for one ballpark figure, then we are talking about 5th percentile and the second trimester scan, when that becomes a soft marker for doubts. We don't straight away say it could be skeletal dysplasia. So to say skeletal dysplasia just on the size alone can be tricky. If we have supportive evidence in terms of bone morphological changes like hypomineralization, bowing, then it becomes easier. Just size discrepancy in one go, I think should be followed up in 3 weeks. If it is increasing, then yes, we should be worried.
Well, the question is that, let's say if I measure humerus or femur on both sides, and I find that one of them is a little bit shorter, then how
very vague thing,
short
Arun.
is,
I mean,
how short is too short?
That will be it shouldn't be short. It has to be equal. That's what it is. So if you find that it is short, then rather than saying it is short, I suggest we follow it up in 3 weeks to attribute significance to it. Okay, just because we have getting some discrepancy, it would be unfair to the patient to label it as abnormal. Rather than, unless we are very sure of it, is my take on it.
I think I seem to remember something like, if it is less than 10%, it is still within okay range. But if it is more than 20%, I think that is somewhere we should start worrying about that. There is something like PFFD or some other issue with the long bones.
The PFFD is very obvious.
Yes,
Even
yes.
mild discrepancy for that matter. We've had cases where there was a right hand was generally smaller than the left. Okay, it was not an isolated thing, but
yes,
all 2 segments, the proximal and middle segments, were smaller. So then that is abnormal because you have a size discrepancy between 2 hands, the right and the left. So I believe, the question per se should be more focused on when you give significance than what Alok says is right. Okay, that's when you give significance. Otherwise, on one go, I believe you should follow it up, look at morphology, look for other signs, And if it is isolated, follow it up, see interval growth.
Brajesh, could you find anything in the literature about this?
No, sir. It was
Okay.
not there. Only thing that pediatric orthopedic was telling, but that was treatment part, not diagnosis part.
I think postnatally, though, it is the 2 centimeter rule they have. If it is more than 2 centimeter difference, then that is abnormal. If it is short by 2 centimeter, that is going to cause problems. If it is less than 10 centimeter, 10 millimeter,
Centile.
yes, 10 millimeter, then the baby can manage.
It is depending upon the age, sir.
Yes, of course.
What that pediatric orthopedic told, in CPMBT, we need to wait up to 7 years. And if at age of 7 years, that age length discrepancy is 5 centimeter, then otherwise that shoes and physiotherapy may be helping.
Correct. So another common question is that if, we've done an anomaly scan and at that time everything was fine, then in the third trimester, we find the long bones are short. They've fallen below, let's say, third centile or even less than 1 centile. So how to go about it? Dr. Vaishakhi, can you take this? What do you do? Unmute, please.
In case of this limb discrepancy, I still would like to go for the normograms. Like, it is not necessary that all the long bones are same for each like upper limb and lower limb or right and left. So we usually go for normogram, and if it is showing associated bony abnormality like bowing or some difference, then we will report it as significant. I don't have one exact normogram that what percentage is described as abnormal difference.
So what about the third trimester short long bones?
Third trimester short long bones, against the same story, whether it is falling below second 2 standard deviation or -3 standard deviation. If it is less than -3 standard deviation, then definitely it is abnormal, and we have to look for the possible skeletal dysplasias, the short long bones and the associated abnormality. If it is between -2 standard deviation to -3 standard deviation, I would like to see the family, the parents, how they are in the height and all. And according to that, we will give them postnatal workup.
We would also like to see the fetal environment. Just in case. So you're right, we have achondroplasia on the back of your mind in the third trimester. We also have statistical variation, as you rightly said. You could also have an FGR component which needs to be evaluated. I think that's the right way of comprehensively covering third trimester growth lag. Small bones.
Also, the associated features, if you're looking at an achondroplasia, then I'd start looking for lumbar lordosis. I'd look for what is happening at whether the vertebrae are really as tall as we like them to be, whether we have a depressed bridge of the nose or brachycephaly and so on. And then also the type of shortening. So if all of that is there, then we say, all right, this is likely to be achondroplasia. And we know that most of the achondroplasias would anyway manifest after 26 weeks of gestation. So we shouldn't be surprised that it actually shows up only in the third trimester and is not shown up at the time of the anomaly scan. So it's not really an error in that term. We know it's late onset evolving anomaly. And but usually the other associated features are so prominent by then that you have your answers.
I think everybody worries about achondroplasia rather than anything else because that is common and it can occur, de novo mutations are common. I think it is the after third trimester, it manifests very, very nicely. You have a short, long bones, you have a big head, you have a femoral neck angle, which is more than 140 degrees. So it's not very difficult to diagnose. There are a lot of features we can see on ultrasound. And if it is not achondroplasia, then it can be anything else. All we have to figure out that whether it is lethal or non-lethal. Of course, we have ruled out the FGR and the short parents, etc. We have to rule them out first. But otherwise, I think we can let them
And you know, we have to begin to start disregarding this short parents theory sooner or later. We tend to think that short parents will have short children and tall parents will have tall children. That doesn't happen anymore. We know that generations are getting taller and taller, provided nutrition is working out well. And we know that paternity is really something that is in doubt over 30% of the times in many of the cases these days, because we have so much infertility with third-party gametes. So in that situation, I think we really have to stop looking at the father and presuming that short fathers will have short babies and things like that. We really must look at the hard evidence that we have rather than looking at a short family. I mean, each one of us sees these on a daily basis, and there are just so many 4 feet 11-inch mothers and 5 feet 1-inch fathers that are having 5 feet 6-inch sons, for instance. And so we really must start looking at all the other features for sure.
True.
And the easiest thing now, of course, is an NIPT. It's just made life so much easier. And the NIPT is available for achondroplasia for the FGFR3 gene. And then we say, okay, we have a diagnosis. Not that it really matters, because I don't think any medical board is going to give permission to terminate an achondroplasia, but it would certainly allow them to prepare for the birth of an abnormal child.
True. Thank you so much for your comment, sir. We have another question. This is about this is directed to Dr. Paras, that he showed a case, the hands did not open, but somebody has a different experience that they did have a case like this. The hands did not open, but after birth, the child was normal. So, yeah, of course, this can also happen. Paras, what's your take on this?
Yes, sir, it can happen. Baby might be the current fetus might be a carrier for the autosomal recessive condition, as can be seen in the genetic report, because only one mutation has been found in the whole exome sequencing report. But considering the the person who is asking the question should also share the family history of his or her case. In my case, the family history is pertinent, that the previous child died in the NICU due to several complications, and there were dysmorphological features as can be seen in the picture.
Yes, I think when we are dealing with the abnormalities, we are always more confident when we have another abnormality to, sort of direct us that, yes, this hand is really not opening. So yes, something is definitely not wrong, not right here. But if it is an isolated abnormality, I will not stop worrying. It can always turn out to be normal afterward. The baby just might be tormenting you for all that he wants.
When we had a case of pointing index finger in second trimester, everything else was looking normal. But on follow-up scan after 4 weeks, the baby started having aortic root dilatation, and that turned out to be Marfan syndrome. So we have to keep a very close follow-up when you see such kind of pointers.
Correct. So my way is that when you have any anomaly, something which is not normal, then we do a very detailed scanning, deep phenotyping on ultrasound. And yes, if something else is there, then we are pretty much confident. Otherwise, we call the patient back again and review it again and again till we are confident that yes, this is a really, really abnormal. And then we have to investigate further.
Yes, sir.
Yes, and in other thing is the baby appearing normal at birth is not it doesn't equals to normal. Many obstetricians and pediatricians also do not consider the relevant history, and they do not deep dive into the genetic testing.
Correct. Some muscular dystrophies they are going to present later on.
Yes.
So another question which is very pertinent is that, is it a medical legal negligence if we miss polydactyly or persistent clenched hands on anomaly scan? What's the take of the audience, the experts here? Would you consider this as a negligence if you miss polydactyly?
If you miss, if it is a part of some syndrome underlying which you have missed, otherwise isolated polydactyly is not a problem.
And what about clenched hands? Because oftentimes when we scan, the baby keeps his hands clenched. Generally, would you wait for, during your scanning for the baby to, capture a image of open hand, at least one?
See, cerebral motor tone, Alok, varies from baby to baby. Just like I would say, there is always an individual variability of fetal distress on fetal heart rate in the same way, cerebrum which develops inside the utero, and that motor tone varies from baby to baby. You cannot apply one rule for everyone. This is what my thought.
So if you're called to give an expert witness, somebody has missed isolated clenched hand. So would you say that he was negligent or not?
Recently, one consultant has thrice seen clenched face and advised amnio. Patient came to me in the morning. Fourth time I have examined, hands were open at the 28 weeks.
It's a matter of chance, matter of luck.
So that's why I
Yeah.
never jump to this kind of findings, and nobody is going to sue you legally for isolated polydactyly or clenched face. If it is
No, but they are actually. You see,
They are.
unfortunately, what is happening is that there used to be the good old straightforward thing where the physician or the sonologist or the radiologist or the fetal medicine specialist missed something, and the patient used to presume that, yes, this is within the limitations of technique. Today, the patient, because the patient is a consumer, thinks that they can buy the world by paying the cost of an ultrasound scan. And most of us are not able to counsel adequately. And even if we counsel, things change so much in the postnatal period because there is the family provocations, there are the professional provocations, and there is the greed of the person to make money through a consumer forum. Because in most consumer forums, currently, most judges seem to be biased and saying that, yes, the doctor missed something, which is why Alok and me are working so hard on a position statement and trying to say that, look, the detection of these problems is limited. And until we have that position statement going, I guess we won't be able to quote that. But this is the reason why we've been pushing it. It keeps going onto the back burner because more information comes out, more guidelines come out. But in most parts of the world, this would be ignored. In India, because of the peculiarity of the consumer that we have, it leads to so much mental distress for the professional that doctors really start getting upset that they've done something like this. Otherwise, for population screening in a busy hospital, we won't wait for the hands to open. But in private practice, for instance, I always wait for the hands to open. And for any one of us who've had even one case against us where there was a clenched fist, we will make sure that for the rest of our lives, we will always make sure that the fist gets unclenched. So we do need guidelines of this position statement like we're preparing now and should be released in a few weeks from now, that indeed we cannot promise the world on the basis of an anomaly scan that these things will be missed. But until it comes out in black and white, there will be patients who will harass us. And this is something we have to learn to live with.
Correct.
Excellent. So this is always a problem. This is always going to be a problem because as experts, we also ourselves are not very clear what all should we take in our scanning, etc. Because some of us will believe that yes, we have to always see an open hand, even though ISWA guidelines they do not comment on that. But I think it is prudent to wait and keep watching the hands, be opportunistic, and capture an open hand because that solves out a lot of problems.
Yes. And both hands, left and right.
Both hands, yes.
Yes, I would never accept a hand below the head like this.
Yes.
I would just wait and wait and wait. Even if I'm missing a flight, I would just wait or reschedule the patient for next week.
Correct.
Rescheduling is always a good idea because these fetuses change their position after about a week, and it doesn't really help to see them one day after the other day after the other day.
I think I was analyzing the medical legal cases which are filed, and majority of them are filed because of limb abnormalities.
That is
not
absolutely
anything
true.
else.
Yes. So for all the missed anomalies currently, if we were to look at all the forums, the district, the state, as well as the national forums, we have almost 35% based for limb abnormalities. And yet every single survey from every single country says that we pick up only between 15 and 35% of limb anomalies, and for the amputational anomalies, what they call the axial amputation anomalies, we're picking up even fewer and fewer.
That is true. I think we have not many other questions. One question is less than 3 standard means what percentile? It is less than 1 centile. And in fact, it is actually lesser than even 1 centile. So because standard deviation measures something else, percentile is it measures something else. So we cannot equate the two together, but measurement wise, it will be 0.3 percentile, I think, as far as I know. That's it. I think we have no more questions. This has been a very fantastic session. Do we have? Mohit sir is here. Yes. Mohit sir, would you like to give final comments? Is Dr. Mayank here? I would like to listen from him also.
I don't see Mayank's name on the list. Yeah.
Okay.
Yeah.
So I think. Okay. Any further words of wisdom from you, Purana sir?
You know, what I really appreciated about the program today was that each speaker stuck to time. It's something that we don't tend to do, and that's not fair for the other speakers, and it's not fair to timekeeping. There are some open-ended programs all over the world, but in most parts of the world, we have to learn to stick to time. We don't have to vomit out everything and let them know how much we know. What we have to do is to teach and let people know what they should be knowing. And therefore, in a program like this, where everybody is mentored beautifully to stick to time, I think I would hugely appreciate that. And I would suggest that all the mentoring that we do, we teach them this as much, that, okay, in a program with this much time, you can present only this much and therefore emphasize these points. And I really congratulate the mentors of the program today and the entire Gujarat group, and Alok, you and heading this whole situation on making sure that everybody stuck to time, that we finished well in time.
This is actually what I've learned from you, how to manage time and how to stick to time and how to respect time. So this is what I have been telling all these young guns whenever I get a chance, that look, you've got this much allotted time, you have to stick to it. And Vaishakhi made sure that we all the young presenters, they are trained to stick to their time. So that is why we have a nice webinar in time. I think that's all.
Yes, sir.
Okay. Thank you everyone for joining us.
so
Hope this was a good, learning experience. Let's see if we are going to meet again tomorrow, the next month, with Kerala chapter for their young ones webinar. And I'm sure we are going to see another set of excellent cases and young presenters. I can't wait, to get that date. Okay. Thank you so much. Good night, everyone. We are going to.
Good night. Good night.
Good night.
Good night.